everybody. I'm Dr. Don Peacock, and I represent the Academy of Ambulatory Foot and Ankle Surgery. I'm an associate professor. And this morning we're going to discuss metatarsalgia and minimally invasive foot surgery. Metatarsalgia, with respect to minimally invasive foot surgery, has a lot of power. You can do a lot with minimally invasive surgery when trying to correct metatarsalgia. So we'll go right into the talk here. This is titled Metatarsalgia and MIS. Now, when you look at the literature, it's kind of all over the place with how you need to treat metatarsalgia. Such things as metatarsal osteotomies, posterior group lengthening procedures, digital procedures. This includes fusions and non-fusions, metatarsal head resections. So if you look at the literature, this is sort of a summary you're seeing here of all the things you'll find in the literature related to treating metatarsalgia. Now, there are three in bold here that we're going to talk about today, and that's the use of percutaneous metatarsal osteotomies. We're going to also show you the endoscopic gastroc recession, and also cases where you need to address the medial column in patients with metatarsalgia. And we do this through cotton procedure, plantar flexing the first met, and also through stenting the subtalar joint in certain foot types. So we'll move on here. This is we're going to talk about what you actually do when you see a patient. What are you kind of looking at when you see a patient with metatarsalgia? They come in with complaints of pain in the forefoot. Well, I have this little mnemonic called ELF press, and these are the things that I'll look at. We look at whether or not the patient has equinus. We look at the location of the pain. We also look at the foot type, and this is extremely important. Foot typing with respect to metatarsalgia is extremely important. And then we do something called the Peacock press, which I will kind of briefly go over with you during the talk today. So remember ELF press when you're looking at somebody with metatarsalgia. So first we look at equinus, and we do this by the cervicoscoid test, a fairly well-documented test. Remember, with normal gait, you're going to need at least 10 degrees dorsiflexion with the foot. If you don't have this, you'll either get toe walking or overpronation of the foot itself. Now, the reason this happens is that when you're in normal gait, the anterior leg will fold forward approximately 10 degrees. So your foot's going to need 10 degrees or you'll have the toe walking or overpronation of the foot. Here's our little cervicoscoid test. You can see on the left, this is the patient with the knee extended, and you can see he's not getting the normal 10 degrees you needed. But when we take the gastroc out of the equation, you can see he gets 10 degrees. So this patient would be a good patient to perform a gastroc recession on. Now, also we look at location, and we follow the Levantine formula. There's some research on this and a very good paper on Levantine. This was taught to me personally by Dr. Stephen Isham, who also taught me how to do the percutaneous metatarsal osteotomies. There's some literature out on the Levantine formula. You can look at that. Basically what this says is it talks about IPK. So if you had a patient with a second met IPK, if you're going to perform osteotomies, you would need to do the second and third. If I had a patient with a second, third met IPK, you would need to do 2, 3, and 4. If you had a third metatarsal IPK, you need to do 2, 3, and 4 osteotomies. If you have the third and fourth, you would need to do 2, 3, and 4. And with the fourth location of IPK, you would do the third and the fourth only. So this is a good way to kind of prevent transfer lesions when doing metatarsal osteotomies. Now, this story is not totally complete, as I'll show you later. Now, with the foot typing, this is extremely important as well. I use Dennis Shavelesson's foot typing system. It's very important. You look at the rear foot as it relates to the forefoot. Now, when you're talking about metatarsalgia, we can limit some of these particular types of foot. The most common foot type you're going to see in your clinic is going to be a person that has a rigid rear foot and a flexible forefoot. Now, so this patient has a lot of pathology. These are the most prominent patients we see in practice. We're going to drop out some of these. The flat foot, those will take fairly extensive surgical corrections that metatarsal osteotomy will not totally take care of, and also going to drop out our rigid foot. This is our cavus type foot, and so we're not talking about that type of foot type. So to see how this gets simple here, we're going to take out our stable foot type, because those patients usually don't have metatarsalgia unless it's an overuse type issue. So we have two foot types we need to be concerned with. That would be a patient who had a rigid rear foot and a flexible forefoot, or a patient has a flexible rear foot and a flexible forefoot. Now, the way that we determine this can be, you can learn this by looking up some of the literature of Dennis Chauvelson, but basically, in a nutshell, what you do, you place the patient in subtalar joint neutral root casting position, and you examine the rear foot in this loaded forefoot position to see if it's flexible, and you examine the first ray as well. Now, that's a whole nother talk, but this is very important. Functional foot type is important. Just realize that you're going to be dealing with rigid rear foot, flexible forefoot patients, and flexible patients as well. And finally, I do something called the Peacock press. We have some literature come out on this. It's more extensive. But when we look at metatarsalgia, we often have x-rays, AP, we have our axial sesamoid x-rays, and they tell us a lot of information. What they don't tell us is how the foot looks at toe off. And also, those tests and those x-rays are hard to perform intraoperatively. The Peacock press is a test where we place the patient in subtalar joint neutral root casting position, and this would emulate the toe-off position, and we press up on the toes 1 through 4, and we look at blanching in the forefoot. If you look at this patient, the blanching is occurring in the second and third met, giving us an indication we would need to do second and third metatarsal osteotomies on this patient. Now, this can also be quantized with the use of an ultrasound, and that's also another talk. But this is a very great test because you can do this preoperatively, intraoperatively, and postoperatively. So, what about this gastroc recession stuff? Here's the thing. There is some effect on the forefoot other than just offloading the pressure. It also affects the first ray. If you look at this x-ray on the top, you can see this x-ray shows a distance from your ground to your navicular as 4.1 here, 4.1 centimeters. And if you look at post-gastroc recession, you can see now that the navicular height has actually increased to 4.9. So what happens with a gastroc recession is if you take out the inability to get the 10 degrees by doing your gastroc recession, your foot is going to pronate less. And so your peroneus longus is going to have a greater pull on the first ray and actually plantar flex the first ray down. And this can be proven. These slides were given to me by Deep Patel and also Barry Johnson, who are just very talented surgeons in our state of North Carolina. And this shows a great effect of the gastroc recession on the forefoot and the way that the first ray plantar flexes after gastroc recession. Also, a lot of literature that shows diminishment in pressure in the forefoot after gastroc recession. This was published by Stephen Barrett, and you can see in this patient, if you look at the left, the patient had a 39 pounds per square inch at a maximum point of pressure pre-op on the endoscopic gastroc recession. That went down to 19 pounds per square inch after the surgery, and that shows basically a 49% diminishment in forefoot pressure. So this is very important. If you diminish pressure, obviously you're going to diminish pain in the forefoot. So if you take all this into account, these are what we're going to talk about. What techniques do we now use in our clinic? We use the percutaneous metatarsal osteotomy. We do endoscopic gastroc recessions. Sometimes we do this open with a small incision that was taught to me by Dr. Laborde. Also, we do the hypercure to stabilize the subtalar joint. And in cases where we have a hypermobile first ray, we address the first ray. I do the Waterman Boney Kessel procedure. You can also do Revere Nice and Bunyan. You can fuse the first met cuneiform joint. There's any way that you currently are addressing hypermobile first ray or a first ray that has a supinator end range motion that is large. we need to address the first ray. So I want to show you now how quick the percutaneous metatarsal osteotomy surgery is. It's a very simple surgery. This would be your the soft tissue portion of the surgery and the dissection of that. This surgery is fairly quick. You can see we make a stab incision. This is under the C-arm. You're actually seeing where you're at. And since this is the patient's right foot, I would make the stab incision a little bit medial because I'm right-handed, because we're going to cut from medial to lateral. We then take a little elevator and denude our soft tissue from the underlying bone. This takes care of our periosteum and gives a good path for our burr to go through without hanging up the soft tissue. So the soft tissue portion of this is literally about 20 to 30 seconds or so. Now we're going to do the osteotomy on the patient, and this is a fairly quick surgical part as well. The channel that we've gotten with our rasp, we'll look under the C-arm, get exact position. We're cutting this at about a 45 to 35 degree angle. This was taught to me by Stephen Isham. It's in DePrado's book on minimally invasive surgery too. We actually will now engage this, do some reciprocal type motions with the cut. Now we're cutting the medial cortex. Now we're into the lateral cortex. When I get to the lateral cortex, we switch hands and put pressure on the metatarsal with the thumb. And when this osteotomy is through, you can feel the metatarsal head actually move up for you. Now it's important to stay in the same plane, so you drop your hand perpendicular. So that's the end of the osteotomy. This can be, you can feel the metatarsal head actually dorsiflex. You can also take your C-arm and pull back on your third and fourth toes, and you can see you'll get distraction of the metatarsal, knowing that you've through your metatarsal. Now for the gastroc recession, normally I use an endoscope for this. Go about 16.4 centimeters or so from the insertional area of the Achilles tendon. Make an incision. I normally address this from the lateral approach and go lateral medial. Make a little stab incision. Before that, you need to mark out where your sural nerve and saphenous vein is going to be. These are the structures you've got to avoid, and that's what my little marks running down the leg are. We underscore this with a blunt elevator here. Enter our cannula, and we're actually going to take our scope and look for the vein and the nerve to make sure it's not in our path of our cut. That's our aponeurosis of the gastroc here. And we cut through that with a hook blade or either a triangle blade. So you do this fairly similar to the endoscopic plantar fascial release. It's just done in the gastroc. Very great procedure. Just have to be careful not to injure your sural nerve or your saphenous vein. In heavier patients, it's usually advisable to open up and actually not do this with a scope. I do this mostly in my slimmer patients that I'm going to have less adipose tissue to have to deal with. So in my larger patients, we'll actually do this open. Now, so this is the patient pre-op. You can see in the cervicaloid test, we're not getting the needed 10 degrees, but after the gastroc on the OR table, we got plenty of dorsiflexion there. Now, in addressing the first ray concerns, I usually do a minimally invasive Waterman and Boney Kessel procedure, which is basically taking wedges dorsally in both the metatarsal and also the proximal phalanx. This also allows plantar flexion of the first ray, believe it or not. Let me show you something I've noticed before in the past. This is the Austin versus the Waterman in terms of how it affects the first ray. If you look at the top x-ray there, this is a right foot on this is the same patient. This is right foot. This patient had basically had hallux laminis, a functional hallux laminis. What I did on the top was I did a plantar flexury Austin with one K-wire fixation here, and we did get some plantar flexion of the first ray. Ironically, if you look at the x-ray on the bottom I did a Waterman. I did this open. This is when I was doing open surgery. I did a Waterman on his first met, and actually achieved more plantar flexion with the Waterman than I did with the Austin. The reason for that, when you dorsiflex the metatarsal head dorsally, you're actually tightening the flexor hallucis longus tendon. and this causes a plantar flexury motion in the first ray. Now, the hallucis longus tendon is very strong. Ballet dancers actually stand on their toe with this tendon. So it's a strong tendon, and it will plantar flex the first ray. This is just showing the depiction of how we do the Waterman and the bony Kessel. We use a burr and cut through under the C-arm. You can see our cut here, leaving the I leave the plantar cortex intact. Same thing with the hallux, leaving the plantar cortex intact. It's a good view showing the plantar cortex intact there. So when a patient stands, this is going to dorsiflex up and decompress the first ray, also plantar flex the first ray. It shows you how much movement we got in this particular patient pre-op and post-op. One thing to keep in mind, that people that have hallux limitus can also have metatarsalgia, because what happens, they begin to walk off their first ray, and so that's not a true metatarsalgia. So make sure your first ray, your first metatarsal phalangeal joint has good movement, because that may be the etiology of your pain. It could be the hallux limitus can be your etiology of metatarsal pain, because if they can't walk over their toe, they will shift their weight laterally. Now, what about these people that have a flexible foot? Well, what I do with these patients, a guy I went to school with and loved him to death, Michael Graham, invented Hypercure, and I use this for rear foot flexibility. I like to tease him, and everybody else does too. He looks like Johnny Depp, so that's why I put this picture of him up here. But basically, if you're dealing with a flexible rear foot, you have to address that before you do your forefoot work, or your forefoot work will not work as good. So in these patients, I do Hypercure mostly, or other procedures if need be, but Hypercure is probably my go-to here. Now this leads us to what I call the Peacock integrated formula. This formula is kind of takes into account not only all the things we talked about before. The ELF press takes into account equinus, location, the foot type, and then we use the Peacock press to make sure everything's working right in the surgical procedure. So if you look at our formula here, we've got 11 different possible things we can look at. So if you look at the top up here, first thing we look at is the location. Let's say a patient had a second metatarsal. We're looking at line 1 here. It had location, IPK or pain in the second met. Look over to the right of your formula here. The GE stands for gastroc equinus. This patient doesn't have gastroc equinus. Now, following the Levitine's formula, which percutaneous metatarsal osteotomy would you do? You would do second and third. However, it's very important to also take into account your first ray and your foot type. Look to the right of the formula, and you see where it says first ray, and a patient would have this exact same foot type, but had a hypermobile first ray, you would have to address the first ray as well. That's why the plus sign is there. And the exact same patient that had a flexible rear foot, you would have to do the Hypercure first before you did all the work. So the formula takes into account location, gastroc equinus, whether it's positive or negative, and then the foot typing, whether the patient has a rigid rear foot, flexible forefoot, which is in the red there. That's going to be most of your patients. Whether the patient has a hypermobile first ray or an increased CERM level, and whether or not the patient has a flexible foot. So let's go down into our formula. Let's look at line 5. Line 5, patient came in with a third metatarsal pain, or IPK. Gastroc equinus is negative. You're going to need to do the percutaneous metatarsal osteotomies on the second, third, and fourth. Do you address the first ray? Well, if the person has a hypermobile first ray or a high CERM level, you have to address the first ray. If that patient had a flexible rear foot before you did anything, you have to address that. So if it was a flexible foot, you would have to do your Hypercure first. So let's take this into account. Let's say the patient has a flexible foot, and they got a third, and their location of pain is in the third met. First thing I do would be do the Hypercure. Then we do our osteotomies 2, 3, and 4. We'd address the first ray if necessary. So you see the formula is fairly simple but complex at the same time. Now, one thing that you have to keep in mind, these patients that come to the office with global forefoot pain, Those patients are patients that most likely are going to be your flexible foot type, and they can be addressed normally only with a hypercure, or they're going to be patients that are going to be more in the line of your pseudoaquinous type foot, and they can be addressed just with the gastroc recession. So let's just go over a couple of those more before we stop with that. Let's say we had a patient, let's look at line 1, had pain in the third met, gastroc was negative. You would do the second, third, and fourth. You would only address the first ray if the serum level was high or hypermobile first ray. You would do the hypercure if you had a flexible foot. Now, line 2, third metatarsal pain, positive gastroc. You'd have to do the gastroc. You do your second, third, and fourth mets, do the gastroc. You would have to address the first ray if it's hypermobile. You would have to address the rear foot through hypercure if it's flexible. Now let's go over some cases here. We'll kind of look at this. Remember, before we go over cases, global metatarsalgia is very important. If you have a flexible foot, you're going to see that in global metatarsalgia. You're going to see a rigid foot. Those are going to be our cavus foot. So for your flexible, you may be able to get by with your hypercure and basically stabilizing your first ray if need be. Rigid foot, these are patients going to be gastrocs, Achilles tendon lengthenings, and even correct their cavus deformity if necessary. So let's do some cases here. Here's a teacher in her 40s, came to us with a dislocated second metatarsophalangeal joint. Basically, this was caused by when she saw another provider who gave her 2 or 3 cortisone shots, which eventually ruptured the plantar plate. Now we got a completely dislocated second metatarsal. So her location of pain was on the second. Her gastroc was negative. She had a rigid, flexible foot, which is the type we see most of the time. And when we did the Peacock press, it blanched on the second and third metatarsals. So how would you treat this? Go into our formula, see the second and third metatarsals blanching. So go into our formula, we do need to do osteotomies on the second and third, which is what we did to her. This is her foot 1 week post-op. So we did second and third metatarsal. We also did some hammer toe work on her fourth as well. And second too, and third. So we did hammer toe work on her as well. So if you look at our x-ray post-op 1 week, you can see now we got our joint back in place here. Osteotomy on the second and third. This patient went on to heal without any kind of issue with her foot and was happy with her surgery. This is post-op 3 months. You can see our second and third metatarsal osteotomies are now healing. The osteotomies in our second and third toes. So this patient went back to normal activity without having a dislocated second metatarsal phalangeal joint. Okay, case 2. This patient has pain in the third met, has a positive gastroc equinus. What procedures would you do? Now, this patient had a foot type we'd call a rigid rear foot and a stable forefoot. Now, this gets a little more complicated, but basically you can look at this as a rigid, flexible foot as well. Preoperatively, he had deviated equinus, and the cervical test clearly shows that. Here's our gastroc recession. Did this in the hospital. In the state of North Carolina, we cannot do surgery in the office. It's above the talus, so we have to do our gastroc stuff in the hospital. This is doing the metatarsal osteotomies. Remember I told you about the distraction. You can distract these and see that you're through the metatarsals. Peacock press afterwards. Now the blanching is much reduced, so you can do this intraoperatively. This is 8 weeks post-op on your left. On your right, this is 8 months. You can see our osteotomies have completely consolidated. This patient also went on to complete relief in pain. Another picture of pre-op and then post-op 8 months. Now, here's something I want to show you. This is a patient that had basically a rheumatological type foot, had some global metatarsal pain, but also didn't have gastroc equinus, just a lot of deformity. And I just want to kind of show you this video just to show you what kind of, how powerful minimally invasive surgery can be. This is just a really nice testimonial and show you this. And run that I want to show you to demonstrate just how much correction you can get with minimally invasive surgery if you look at her left foot, this is 3 months post-op, and we performed a bunion on her, an Aiken, a Taylor's bunionectomy with an osteotomy, and Isham hammer toe corrections on digits 2 through 5. This is only 3 months later. She's doing well with her foot. She's never had to be off of her foot. There's no pins or screws in her foot. To give you an idea of how much correction we get, now today we're going to do her right foot. Her right foot has a similar deformity that her left foot had. So what we're going to do is we're going to take wedge osteotomies to move all the toes in place and perform tenotomies, and take the bunion off here, do a Taylor's bunion here, just to give her a more cosmetically pleasing foot like she has on her left foot. So now with this patient, we opted not to do metatarsal osteotomies, and there's a reason for that as well. When we looked at her metatarsal osteotomies in the Peacock press, we had sort of a uniform blanching there, so we didn't need to address her metatarsals. They were in pretty good position. This was mostly the toe deformities that were bothering her, and the abnormal pull due to the rheumatoid issues and underlying neurological issues. This patient also had myasthenia gravis as well. Okay, so here's our conclusion. Basically, it's very simple. Minimally invasive surgery is very powerful for the treatment of metatarsalgia. As a matter of fact, when compared head-to-head with traditional surgery, there's nothing wrong with traditional surgery. I'm a proponent of both traditional and MIS. I think they're both equally powerful. However, in the case of, in my hands, when treating metatarsalgia, I have to give the edge to minimally invasive surgery. It is just very powerful in the treatment of metatarsalgia. It can hardly be done. You can hardly do this in my skills with traditional surgery. So it's very powerful. Certainly worth investigating. If you decide to do minimally invasive surgery, you can do all your other traditional stuff and you'll get great results. But with this lesser metatarsalgia issues, I believe that minimally invasive surgery is superior when it comes to correcting metatarsalgia. Thank you very much.